Good evening and welcome to our COVID-19 update program. I am Ladi Akiridoluale. Here are the highlights for this hour. Anambra State lawmakers express satisfaction with the state of COVID-19 treatment facilities. Kaduna State healthcare workers start 7-day warning strike as government threatens to sack them. And United States COVID-19 death toll approaches 95,000. Members of the Anambra State House of Assembly have commended the proactive measures taken by the state government to contain the spread of COVID-19. The lawmakers expressed this satisfaction when they inspected the protective care centers in various parts of the state. According to the Deputy Speaker of the House, Mr. Pascal Abodike, the various facilities speak volume of the state's preparedness to contain any emergency.
With 4 confirmed cases in Anambra State, members of the State Assembly Ad Hoc Committee on COVID-19 Prevention are out to see if the state is ready for a possible surge. The mission is to inspect the protective care centers and measure the level of compliance to the ban on interstate movement. Their first stopover is at the Protective Care Center at Umuawulu Mboku, where the State Commissioner for Health walks them through the 240-bed facility.
The capacity is such that we can blow this out to 1,000 beds. We currently have the capacity to take 240.
It is very, very pertinent that we communicate to Anambra that COVID-19 is real. We've gone around, we are seeing that Anambra State is prepared to fight against COVID-19.
Next is the Onitsha Protective Care Center with 58 beds. It's a highly infectious disease unit section with restricted access.
Each of the rooms have a lot of gadgets, centrally piped oxygen, rooms built in suite, and then ventilators and other facilities you have there, like the airline, one of the resuscitators that when you use it on a patient that is, has hypertension, you notice that you can infuse a lot of fluid in that individual under 2 minutes to resuscitate them if they are in shock.
Third on the list is Aguleri Protective Care Center, which is equipped with 12 beds and ventilators.
Oxygen saturation, which for COVID-19, for example, is it's a very important parameter to check in those patients, the saturation level, how the red blood cells are saturating oxygen.
The committee rounds off their inspection at Amansia, the border between Anambra and Enugu State, where they ask security agencies to do more to secure the border.
From the southeast to the north central, where in Kaduna State, health workers have declared a 7-day warning strike over the 25% deduction of their April and May salaries as contribution for the management of the coronavirus pandemic. Their unions are also demanding for the inclusion of all health workers in the hazard allowance package of the state government, as well as providing them with adequate personal protective equipment across all public hospitals in the state. They also threatened to commence an indefinite strike from June the 5th if their demands are not met by the Kaduna State government. The state NMA chairman, Dr. Stephen Kache, who addressed reporters on behalf of the joint unions, described the 25% deduction of healthcare workers' salaries as illegal.
Arising from our meeting today, the union noted that apart from the 25% of the salaries of healthcare workers that were deducted in the month of April, another 25% deduction has also been effected in the month of May for all healthcare workers in Kaduna State. This is unacceptable and is insensitive to the needs of the healthcare workers in Kaduna State. This meeting also noted that there are inadequate personal protective equipment within our hospitals across the state. So our demand now is a refund of the 25% taken in April and that taken in May, and a subsequent stoppage of further deductions. If in the next 48 hours, by 48 hours I mean by Friday 12 noon, the government does not reverse this order and does not meet the demands of the healthcare workers, all the healthcare workers unions in Kaduna have agreed that we're going to proceed on a 7-day warning strike.
Despite the strike by the health workers, the Kaduna state government has vowed to keep its facilities running and also protect staff that are willing to provide services to the public. The government made this known in its official response to the notice of strike issued by health workers, saying it will not succumb to blackmail. A statement by the governor's special advisor on media and communication, Muyiwa Adike, warned that government will regard persons who fail to show up at their assigned places of work as having forfeited their employment. He also warned that those who are not willing to work are strongly warned against criminal actions such as attempts to impede access to workplaces, harass willing workers, or to sabotage facilities and equipment. According to him, government will not be misled into granting health workers a special status amongst public servants. Federal health authorities are said to be thinking about a shift in strategy in COVID-19 patient care. According to the Director General of the Nigeria Center for Disease Control, Dr. Chikwe Ihekwazu, this shift in strategy, which is still being considered, may involve allowing for home care and isolation for some categories of patients relating to COVID-19 health care. Dr. Ihekwazu spoke at the last briefing of the Presidential Task Force on COVID-19 held yesterday in Abuja.
We're thinking about community management. We're thinking about home isolation. We haven't come out with any definite policy on this, but we are thinking about these things because we have to. It's not a choice, it's not an ideal scenario, but these are the realities of managing cases in our context, and we're looking at all the choices available to us, and we will have to make those decisions. We will make the best decisions available to us in the best interest of everyone, together with state governments, together with local governments, together with the private sector, to provide the best possible care for our people. Having said that, this is a new virus, and we're learning. Every day we're learning about transmissibility of the virus. Up till now, we have kept patients in care or advised that patients be kept in care until they turn out to be negative on the test that we're using, the PCR test. New evidence is emerging that even when the test is still positive, that in certain circumstances after that patient has been in care for a certain amount of time, it is possible and safe to discharge that patient to home isolation. So we're looking at the evidence, and we might change our guidelines over time. And I'm sharing this so that we start preparing ourselves for some changes in direction of how we are planning to go. But also to say that we are learning. There are no definites in this response. And the key thing is that we are ready to look at emerging science and change as we learn more about this new virus. We must never forget that we're in May. This is the month 5 since this new virus emerged. There's no other disease, as far as I remember, that we have learned so much so quickly as we have evolved our response. And with every new bit of knowledge we learn, we tweak the response a little bit in order to make it better.
Meanwhile, 56 persons who tested positive to COVID-19 in Borno State have opted to isolate at home. The Borno State government says it is a welcome development which has worked well in the management of the disease in the state. Its Commissioner for Health, Dr. Saliu Kwayubara, says the people are carefully selected and are currently cooperating with officials, resulting in the successful management of their cases.
From the early days of COVID-19, Borno State have been practicing the home-based isolation. Now, out of the 235 cases that tested positive, 56 persons had opted for the home-based isolation. And as I speak at this moment, 30 out of that figure have tested negative twice and have literally been discharged from isolation. Now, the beauty of the home-based isolation is that it eases the psychosocial burden and stigma on one hand for the patient, and on the other hand, it reduces the burden on the government. We are talking about the burden in terms of feeding, bed space, and other recreational needs of the patients. As I speak, the number of active cases in the state supersedes the capacity of the isolation center provided by the government, which is just a 100-bed facility. And we understand also that the facility is just 50%, 50% of the facility remains unoccupied. And this is a fallout of the home-based isolation that we are talking about. However, there's a criteria that a patient seeking to isolate at home must meet before they are granted their desire. And this is according to the Commissioner of Health.
We have quite an enlightened number of people whose homes are divided into several apartments that are independent. And often you have an apartment where people can stay away without mixing with other members of the family. So once we meet those kind of conditions available, then with a well-enlightened group of people, duly counseled, we allow them to go on home isolation if they so choose. The team then shares contacts so that they follow them up on a daily basis, measure their temperatures, make sure that they take their drugs, and then follow up on their symptomatology. And then as the symptoms begin to wear, or once they get to 14 days, then the repeat test is done for exits. And as I speak to you, we've discharged quite a number of people out of home isolation.
Blessing Tuno Aso for COVID-19 updates.
Thank you, Blessing. Let's talk at this point to our correspondent in Abuja, Kayla Megwa. Good evening, Kayla, and trust that you're staying safe. Since Dr. Hekwazu broke this yesterday during the daily press briefing of the Presidential Task Force, what can you tell us about the reactions that have met with this proposal?
Evening, Ladi. The idea of home isolation, it's feasible, but like Mr. Nhekwazu said yesterday, the problem with it is the living conditions of many Nigerians in the country. You know, many people live in houses where there are up to 10 people inside of it. So, and then maybe it's a 2-bedroom or a 1-bedroom. How are you going to be able to isolate yourself in a 1-bedroom or in a 2-bedroom? You know, when we have 10 people living there. So these are some of the challenges. Of course, every single type of solution that has come up to this disease depends largely on the realities on ground. So if we have a housing problem, we do have a housing problem in Nigeria. Self-isolation at home might be difficult. It will be a little difficult for people to be able to live in the same house with someone who has the disease and not contact that disease because there's always a lot of close contact. We have bedrooms where people share 5 people to a bedroom, or the kids are in 1 bedroom, or the girls are in 1 bedroom, the guys are in 1 bedroom, the parents have another bedroom. So the living conditions will be a problem in that. But I also understand the part of government. And that's some of the reactions I'm seeing, understanding where the government is coming from. Because we have all these, let's talk about the returnees, where we're going to keep all of them. If we actually start to do the testing in the numbers that we want them to be, how many isolation centers are we going to have? Is the whole country going to become an isolation center? Are we going to turn every hotel into an isolation center? The capacity just isn't there. And I think the PTF are able to admit this, because that was the admission yesterday. But they said they are looking outside of the box. And when they come up with something that works with our realities, they'll let us know, Ladi.
The other question, of course, is that if you're going to allow people to self-isolate or isolate at home, then it also speaks to the individual discipline of the person who is doing the isolation. Because all the facilities may be there, but if these are people, like we heard stories about some of the returnees who were attending to visitors, even though they were under quarantine, they were attending to visitors and they were collecting food and medicine from outside in some of the centers. And then you had some of the others who burst out of those centers. If this goes on at home, how viable is the home isolation or home quarantine process going to be?
I mean, there was something the health minister explained to us yesterday. He said, when you are going into quarantine, when you're coming into the country, and they tell you that you're going to be in quarantine for 14 days, you sign a document, you sign an agreement saying, okay, I will keep to the isolation center rules. But he admitted that there were many people who were not keeping to those rules. They said they were going to tighten security on those particular, isolation centers to make sure that people adhere to the rules. He's urging people to be people of their word. These are evacuees, people who have come back into Nigeria. Now, if we're having people who have signed waivers, have a clear understanding of what the situation is, understand why they need to be in quarantine, still not doing the right thing, let's talk about someone who lives in some village somewhere in the country. Would he be able to adhere to the rules of the isolation in his house, not going outside, not having people bring food and touch your hand? How do we know one day he doesn't pop out of the room or she doesn't pop out of the room and say, I'm tired, I don't have any symptoms, I'm coming to sit in the living room, no one should talk to me, So it's a lot of individual responsibility, which is why as long as the PTF say they're trying to look outside of the box or look for ways to manage the situation, they have to come up with something that is realistic for the reality that we have in Nigeria. We have a housing problem, like I stated earlier. Individual responsibility is a problem. And of course, we have also the burden on the government to handle this problem. So it's a lot of awareness. Engagement might be the way forward. If people understand, how important the situation is, and if I'm in quarantine, if I'm in isolation at home, these are the things I'm supposed to do so I don't infect my family. If maybe more engagement with people would make them, would make Nigerians, take more responsibility, and maybe the isolation at home might become possible at that time.
Thank you very much, Kayla, our correspondent Kayla Megwa, reporting from our Abuja studios. Do enjoy the weekend festivities if you can, but do stay on and keep safe. Thank you very much, Kayla. Let's talk also to our correspondent in Lagos, the nation's commercial capital. That's Olu Phillips. Olu, good evening. And what are you hearing about this home isolation / quarantine proposal? How are the reactions been coming in? We seem to be having a bit of difficulty with Olu's audio. Let's hope that we can get him back in the course of the program. While we're doing that, let's expand the discussion on the proposed home-based management of some levels of COVID-19 patients. We're being joined via Skype by a consultant public health physician who is also chairman of the Lagos State chapter of the Association of Public Health Physicians, Dr. Tolu Olufunlayo. She joins us from the Yaba area of Lagos. Good evening, Dr. Olufunlayo. Thank you for your time.
Good evening, Ladi. Thank you for having me.
What do you make of this proposal?
Thank you. Well, it appears that we've come to a point where, as has been said, we really have to think outside the box. With the projections for the number of cases of COVID-19 in the near future, for example, in Lagos State, models have projected that we are going to get to somewhere between 90 and 120,000 by July. We definitely have to think of other strategies, because even if we build so many isolation centers in the next few weeks, we are unlikely to be able to cope with keeping everyone in formal isolation.
Well, at this point, we want to take a break, a very brief break, Dr. Olufunlayo. Please stay with us. When we return, I want to ask you about some of the implications of this in terms of how people are behaving currently and how they probably would or could behave if this becomes a real. That will be after the break. Do stay on with us. Thanks for staying tuned. Welcome back to our COVID-19 update. I've still got Dr. Olufunlayo on Skype joining us from Yaba. Thank you so much for your patience, Dr. Olufunlayo. Before we took the break, I said I was going to ask you about what we have witnessed so far, and that was what I was talking to Kayla about in Abuja, about the behavior of those who are actually in official isolation and official quarantine, who are being monitored and supervised. Some still have managed to break the rules. Now, if they're going to supervise themselves more or less by being at home, how do we ensure that that goes on and they don't spread this to other people? That's apart from other problems in terms of how their housing arrangements may be.
Okay, thank you very much. Permit me to first of all start by saying we had the privilege today, that is the Lagos chapter of APHPN, of having a virtual discussion with the Honorable Commissioner for Health, Lagos State, and he was able to bear his mind on issues relating to home isolation and some of the plans that are in the offing. Now, coming to the behavior of people in isolation, one of the things that would be critical to the success of such a proposal or such a concept would be engagement of the community. If the community is not going to take responsibility, then there'll probably be challenges. So it's really important now that we begin to raise up a team from the community level, train them, engage them on how best we can monitor and supervise people who are self-isolating, who are being isolated in their homes. And I must say that this approach, at least from the Lagos State point of view, they are planning an integrated approach, that there are going to be so many different parts to it. And it looks good on paper, but the challenge definitely is going to be its implementation. So again, we have to come back to looking at how we engage the community and make them understand the realities of this infection so that they actually do take responsibility. And if I think well, I think what the people in Borno are doing, there must be some strong community component to it for it to actually work.
One of the things that Kayla pointed out is that some of those who have broken the rules so far are those who have actually signed official documents indicating that they accept to abide by the rules. So again, I want to emphasize the issue of self-discipline. And when you talk about community ownership, again, people have the right to exercise their freedom, so they'll tell you. And therefore, the question then arises, how do you ensure that these people, once they are placed in home isolation, abide by the rules, if what we're doing so far is to simply persuade them, get the community buy-in, and we don't play up the issue of enforcement of the rules?
Well, that's not to say that enforcement may not come into play, but we always say that it is better to get people to understand and comply. You can only enforce so much. You cannot be with people 24/7. You can't be with them all the time. So it's still important to get the community's buy-in. If the community buys into the program, they will become your enforcement agents. They would be the ones to either make sure that these people comply or report people who are not compliant. But they must first see the value in what is being done. And that is why we must engage the community.
One final question, and I hope you can answer this in about a minute and a half, and that has to do with stigmatization. Once someone has been identified as a COVID-19 patient, and the person returns home to self-isolate and quarantine or whatever, maybe take treatment of any type, isn't there the very likely possibility that everyone else will take off, including those who are supposed to ensure that the person keeps to the rules?
That is possible, but it depends on how it is handled. It still goes back to the community, understanding what this infection is. If it is broken down bit by bit to the community to see that this is a highly infectious disease, but if it is well managed, most people recover. And once they recover, they're unlikely to come down with another infection, and then they can come back into the society. Then you would find out that eventually people would want to safeguard their loved ones and would want to actually, protect those that have the infection. So we must do aggressive community engagement from the bottom up. Find out what are the barriers to people imbibing positive behaviors. Why are people running away from isolation? Why are they running away from people that they believe have this infection? We must do all these things, and that is where research comes in. And I'm happy to say that, you know, data is being collected. We can see that the system, both at the state and even the federal level, is responsive. They are willing to make changes when they see that what we're doing is either not working or has reached its limitations. And that's why we are getting into this decentralized mode of managing COVID-19 cases in the first place. I must say that other institutions will be involved as well. There'll be private hospitals involved, those that will be able to meet the requirements. And we are going to have to, you know, make sure that there's a link between these people who are home isolating and the health workers. The healthcare team is going to be heavily on ground from the model that is being presented to us, because these people must be closely monitored, not just for breaking isolation, but also for their health. Because we know that some people will still progress to moderate to severe forms of COVID-19. And those people will need to be taken into isolation in a formal center for proper care and support.
Dr. Tolu Olufolayo, thank you very much for your time and for your insight on this very sensitive topic. It's been a pleasure having you join us.
Thank you.
I understand we can go back to our correspondent, Olu Phillips, now, who is ready to speak to us. Now, Olu, if you can hear me, what exactly has been the initial reactions, if you like, to this very novel proposal for home isolation and care?
Ladi, good to have you again this evening. I'm sorry about those hitches. Technology is technology. It's about a mix. It's mixed right now. When I talked to people earlier in the day, and it's not unfounded. The argument on one side is that there's this mentality that we attach to certain kind of ailments. Imagine how long it took a lot of people to realize that mental health does not necessarily mean madness. So you had cases in the past where if you had mental illness and you are referred to Yaba, they say Yaba left, meaning you're mad, as it were, or you're crazy. But this is not the case. Mental health is like every other ailment. So COVID at some point is looking like a stigmatized ailment where the isolation center has also become a form of a stigmatized center, which have developed some kind of phobia in the minds of people, and they're beginning to fear to go to the isolation centers. So the other part of the argument is if they bring it back home, which of the hospitals or which of the centers will be recommended for this? It's important that we are very clear of this homegrown strategy we are about to deploy, even though it's yet a proposal, because a lot of people don't live disciplined life. And you don't want, in the name of home self-isolating, transmit this to other members of the family or other members of the community. And we have a communal and a provincial and a cultural way of living that doesn't allow for this kind of isolation. So, but at some point, it reduces the kind of stigmatization that is attached to the larger house, which is the formal isolation center. But let's face it, these places are overwhelmed. The numbers are going up. And we're also having discharges. If we have discharges, it means that our doctors are doing some kind of treatment, and applying some kind of remedies that can be distilled at the domestic level if this proposal sails. But it's been a mixed bag for the community people that I spoke to today, Ladi.
Thank you very much, Olu, for that reporting. Our correspondent, Olu Phillips, reporting also from Ikeja in Lagos. 339 new cases of COVID-19 have been reported by the Nigeria Center for Disease Control, the NCDC, and that has taken the total number of confirmed cases in the country to 7,016. The number of those who have recovered from the disease continues to rise as well, standing at 1,907, just as the death toll has also risen to 211. This leaves the number of active cases at 4,898. The new infections are in 17 states and the Federal Capital Territory. Taking the figures region by region, in the southwest, Lagos State remains the epicenter with the highest number of confirmed cases at 3,093. Of this figure, 2,471 are the active cases on admission. Next is Kano in the northwest with 875 cases. In the north-central region, the FCT has the highest number of cases at 446. Taking out the number of discharged and fatalities, the FCT actually has 290 active cases. Borno tops in the northeast, but with the total confirmed cases unchanged at 235. Edo leads in the south-south with 144 cases, and Enugu in the southeast has a total number of 16 confirmed cases. Dr. Jamiu Ganiu, another public health physician, joins us in the studio now for more about this. Good evening, Dr. Ganiu. Thank you so much for your time.
Yes.
We're taking a look at this home isolation proposal for treatment of COVID-19. First of all, how does the proposal meet you? Is it something that is actually doable?
Actually, to start from, I think it's doable because considering the fact that we're having more cases and it may get to a point at which maybe the number of cases may outweigh the isolation centers. So therefore, we need to start thinking outside the box. And the idea of home care is not new. It's been done in other countries. The only thing is that there's not everybody that will meet the criteria. There are going to be a checklist to see those that will meet that criteria. And this is based on science. Based on our epidemiological data, it has been found that about 80% of cases are asymptomatic. When mild to moderate cases are about 10%, then severe cases 5%. And majority of time, some of these asymptomatic cases are taken to isolation center without being offered any form of medicine and so on. They get disturbed as if they're just there, they're just wasting their time. I think people like this will benefit from home care. As I've said, it will require some criteria. Like, for instance, the WHO criteria stated that somebody must be an asymptomatic case and he must not have any of the risk factors, like maybe being hypertensive, be diabetic, or having other comorbidities. And at the same time, there must be a caregiver in the sense that who is willing, who must be a family member, the spouse of that person, who is ready to help out. And apart from that, there must be a kind of environmental assessment to look at whether that house is actually visible. Looking at the number of people there, you can't expect like 10, 15 people in a one-room apartment and you want to carry out home care. It's not possible. And also you have to look at the members to see whether there are elderly people, 60 years and above, which is another consideration.
Risk group.
And in that situation, you have to look at the ventilation of that setup, whether actually it's fit for that kind of approach. And as well, you have to also look at the issue of infection control. That the person that will be engaging in the management of that person must also be trained on basic infection prevention and control. And again, there must be an healthcare worker. That's why the issue of community engagement is very important. Maybe the people working at the PSC, because one of the core functions of PSC worker is to carry out home visits without COVID-19. So they will be, we are talking about monitoring.
Right.
They will also help out in engaging such kind of patient in terms of maybe it could be through call, it could be through telemedicine, or it could still be by face-to-face as the case may be. And it's not that, in case there is any problem, like maybe the person develop any complication, there will be a kind of a process whereby that person can be taken to the main isolation center. So there is a guideline for it. I think that has been practiced in other countries and it's working. And I will not tell you that that is the way forward. Because we are just having about 7,000 plus. We don't know what will happen when it will be, maybe in the next 4 weeks or so. So we need to start thinking outside the box, which I think is...
the caregiver that you mentioned and the other family members who will be in the home with this person, they also undergo training.
Yes, there may be an informal kind of thing, telling them how to wear face mask to ensure that such patient should only be using one cooking utensil, one plate, one spoon. They must not share the certain things together. Even and the issue of the contamination, maybe on a one daily basis. And if they need to, such patient can be in one room the guideline even say you can be in the same room, but the only thing you maintain 1 meter apart with either of them wearing face masks. So those that are guidelines to that effect, which is actually working in some countries. I think with, as we said, with taking self-responsibility and proper engagement, I think it is workable in Nigeria. But my only worry is that it may not be for everybody. For those that meet that criteria, I think it's a workable approach to.
From what you've said, what
Yes.
what it seems that I can get, one is that since it will not be for everybody,
Yes.
if we get overwhelmed in terms of the facilities,
Yes.
we will still have to look for facilities to put the people who are not qualified, given the guidelines you have given.
Exactly.
It's just that the numbers may
Yeah.
not be at the level as if everybody was going to be isolated.
Exactly.
Which means then that one does not expect that a large number of people, given all these guidelines you've listed,
Yes.
there's no doubt that a large number of people cannot qualify with all these criteria.
Well, it depends. I don't want us to just presume. I think, and again, that's WHO guideline.
That's right.
We need to adapt to suit our own system.
That's right.
Maybe our own will find a way out. As I've said, you can't expect 50 people in one room and you say you are doing home care. It's not possible. You get it? So, and again, you cannot have an elderly person. That's why I remember our chair just mentioned we had the discussion with the Honorable Commissioner of Health today. And I think the issue of reverse isolation may arise. For instance, if somebody, maybe a patient, is with his own mother who is about aging parents, and that person is the patient is posing a risk to such kind of person.
Right.
The elderly person may have to be moved out
of the house. Of that location.
Because that's what called reverse isolation, which can also happen. So we've, as the director of NCD has just said, we've not really come to a conclusion
that this is what we're going to do.
But I think that's one of the way forward. And I want to clear one thing.
Right.
That is, the approach is not a new thing entirely. It's part of integrated care that is being offered for COVID patient. It's a kind of, it's part of the entire management, not that it is done in isolation.
Indeed.
Yes.
All right, then. Thank you so much, Dr. Jamil Gani.
Thank you
so much for
you.
this insight.
Thank you.
It's been a pleasure having you join us at this point.
Thank you.
Let's take this discussion across our borders to Chatham in Kent in the United Kingdom, where a family medicine physician, Dr. Sule Hassan, joins us from. Good evening, Dr. Hassan. Thank you for your time.
Good evening. Thank you for having me.
How does this isolation, home isolation system work in the United Kingdom?
Well, the home isolation is a simple system which empowers the individual to declare himself sick, self-satisfy himself sick. So he does not really need to see a doctor, because the usual UK law says if you are sick, you have to see a doctor to get a sick certificate. So to remove that workload, the idea of self-isolation came in. So the person says, I have fever, or I have a cough, or I have lost my sense of smell or taste. Those three symptoms, that entitles him to self-isolate for 7 days. And anybody else living with him in the house has to self-isolate for 14 days. So there is a diagram for self-isolation. So we don't take anybody to an isolation center here in UK. You simply say, I think I have COVID infection, and you stay at home. This helps to prevent you from infecting family members or friends or colleagues at work. So that's the idea of self-isolation. The isolation as understood in Nigeria, coming to take people away from their homes to a particular center, is foreign to us.
We'll take a break, Dr. Hassan. We'll come back to you. Please stay on with us. We'll come back to you after the break, because there are other questions having to do with this home isolation. Please stay on with us as viewers. Thanks for staying tuned. Dr. Sule Hassan is still on Skype with us from Chatham in Kent in the United Kingdom. Dr. Hassan, I know you said before we went on break that isolation works virtually for everyone in the UK and that nobody is taken to isolation centers. But there are risks and there are implications for this. Could you talk to us quite briefly about those risks and implications?
Well, the risks, as mentioned by your previous speaker, is basically, and which I can foresee in Nigeria, is a situation where the person who has a symptom is living in what we call a multi-generational household. That is, you have the grandparent, you have the parent, and you have the children. And one person in the household develops COVID-19 symptoms. Then, and they live maybe in a very crowded accommodation, then really self-isolating in that situation becomes a little bit problematic. You could take the person out of the household to a hotel, for example, or basically you treat the whole household as a unit, as one sick person, and they all have to self-isolate according to a certain guideline for the next 14 days. So that is the other conditions I see different, which might be difficult in Nigeria, is the fact that there are many areas where people live congested. So actually the idea of self-isolation or social distancing becomes problematic.
Now, taking a look ahead, because what is fueling this is the thought that it's quite possible that Nigeria is not yet at the peak of its cases, and that in terms of our facilities, we may get very quickly overwhelmed when we are unlocking the lockdown that had been in place previously. What would you recommend that we could do, if not this home isolation, that could help in that regard?
There is really no other way out of it other than to advise the government in Nigeria to immediately adopt the policy of self-isolation, that is, empower the citizens to be responsible or take responsibility for their own health, and also to care for the other individuals or family members by declaring themselves that they have the symptoms and they have to stay at home for the next 7 days or 14 days. And that removes the issue of stigmatization, of taking people to isolation centers. I will actually have wanted that the term isolation center be turned or changed to isolation treatment center, to show that people are going there for treatment. So you will take only the seriously sick to isolation treatment centers, and anybody who has a mild illness should stay at home. We know that 80% of the people who get COVID infection are going to have mild symptoms, especially the young people. Nigeria has a huge population under the age of 25 years old. About 63% of the population in Nigeria are under the age of 25 years. So they are going to have mild symptoms, apart from the ones who, of course, have serious illnesses. So if 63% of the population are going to have mild symptoms, why are you locking down the whole country? The population that are going to have serious illness are those above the age of 65 years of age, and there are only 2.7% in Nigeria. So we are talking of less than 6 million people.
All right, then. Thank you so very much, Dr. Hassan, for this insight and for the piece of advice to the Nigerian authorities. Dr. Sule Hassan is a family medicine physician, and he joined us this evening from Chatham in Kent in the United Kingdom. Thank you so much for your time.
Thank you for having me.
The COVID-19 death toll in the United States has reached nearly 95,000. The actual figure is 94,701, as the country continues to have the highest number of confirmed cases worldwide. This is coming as coronavirus cases in many Latin American countries have been rising sharply. The death toll in Brazil has surpassed 20,000 after a record number of deaths in a 24-hour period, with over 300,000 confirmed cases. Now, if you want details of all of this and others, please go on to the websites of the World Health Organization. they have details of this and indeed others. For the details and the stats of the Nigerian one, do go to the Nigeria Center for Disease Control, the NCDC. There you'll find the latest figures of the stats, the breakdowns, and all of that. And of course, Channels Television on channelstv.com has both local and international perspectives on COVID-19 that have been confirmed in more than 5 million people so far. You can also check out our website for news and happenings in other spheres. Thank you for being with us. My name is Ladi Akeredolu. Do have a good weekend ahead. Good night.